Warm welcome delegates on the platform of webinar DIA 5 Scientific Series program sponsored by Panacea Biotech. Panacea Biotech is in the healthcare for more than 3 decades. Most important in vaccines, organ transplant, drug immunosuppressant drugs, pain management, and anti-diabetic agents. As you all, as a diabetes management and diabetologist across the country knows Panacea Biotech very well by launching the first generic of glycoside, Glycemic. Today's on this academic platform, we have moderator chairperson for this session is Dr. V. Mohan, with the speaker Dr. Manoj Chadda and Neeta Deshpande. Dr. V. Mohan is a pioneer and veteran diabetologist in a country and known across the globe. His main research interest in epidemiology of diabetes and its complications, genomic of diabetes, and his research work, whenever the Indian data is referred, each and every article is referred and referred by the scholars and researchers to understand that what is diabetes in India. He's conferred by fellowship from all the 4 Royal Colleges of Physicians, that is most important. Received over 190 awards, including Dr. B.C. Roy National Award by Medical Council of India and Dr. Babasaheb Ambedkar Centenary Award for Excellence in Biomedical Research. What is important in biomedical research in diabetes, as everyone knows that in every decade we get the new mechanism of action of the drug. And here the doctors V. Mohan and the other endocrinologists plays most important role to make it understand and use this anti-diabetic agents across the patients. Also, he has received Dr. Harold Rifkin Award from the American Diabetes Association and is the first Indian to receive this award. Recently has confirmed the fellowship of the Royal Society of Edinburgh. His academic interest and teaching to the students and postgraduate students and doing the research works is very well endorsed by the 1400 papers published. And he is a guide mentor to the majority of the diabetologists, those who are practicing in India, as India is the hub of or capital of the diabetic patients. Also, the 200 chapters to the textbooks on diabetes and internal medicine is a contribution in the medical college education. In 2012, Dr. Mohan was awarded the Padma Shri. This is one of the prestigious award given to research scholars, civilians from the government of India for contributing and serving to the community, society, and entire human being, and the highest award in the country by government of India. Dr. Mohan is also an author of the book Making Excellence a Habit. He made the lifelong disease of diabetes with the full of complications, very simple, very adaptable to the lifestyle to the common people. And therefore, the secret of building a world-class healthcare system in India, this book, which published by Penguin India, which is a bestseller on Amazon India. We are happy that Dr. V. Mohan is here to moderate this session. I request Dr. V. Mohan to take up the session and introduce our speaker. Over to you, sir.
Thank you, Dr. Kunal, for those kind words. I'd like to thank you and Pallavi and the whole team from Panacea Biotech for organizing this very interesting meeting in which we have 2 very eminent speakers and very good friends of mine, Dr. Manoj Chadha and Dr. Neeta Deshpande. What I'll do is I'll give a very brief 5-minute kind of overview about the early initiation of SGLT2 and DPP4s in diabetes management, and then we will go to the 2 speakers. So that we are all on the same page, we must realize, and it's worth emphasizing, that we have a huge burden of diabetes in India, 77 million with diabetes, second highest in the world. Now, we have several classes of anti-diabetic drugs, 7 classes to be precise, apart from insulin. And why the SGLT2 inhibitors? They have come with a bang a few years ago, but every year, the last 2 to 3 years, we've been seeing this class of drugs create history. It started off as a humble anti-diabetic drug, which we all thought will soon go away because it's working on the kidney, and diabetes already stresses the kidney. And how is this drug ever going to see the day, light of day? That was my initial impression many years ago when they first talked of this agent. How wrong I was proven by the initial trial itself, where apart from the blood glucose control, reduction in blood pressure, reduction in weight, and many other benefits were shown. But then it didn't stop with that. It went on and on to create, history by becoming a cardiac drug and now a renal drug and probably a hepatic drug as well. Both the ADA, ACE, and all guidelines have now started placing this compound in a special box, which we'll be talking about. And we know that apart from the glucose lowering effect, the SGLT2s have many other benefits. For example, effective glycemic control, blood pressure control, weight reduction, but also reduction in cardiovascular death, heart failure, hospitalization for heart failure, slowing of the progression of chronic kidney disease of CKD to end-stage renal disease, which is very important because this is one of the commonest causes of death in people with diabetes. And so the ADA and EASD have already recommended SGLT2s post-metformin. We have not yet said first itself to take it. Probably that will also change in the years to come. But right now, where we place it is after metformin. If you have established CVD, congestive heart failure, CKD, or a very high risk of these, then we should consider SGLT2 as the next drug after metformin. And the heart associations have also started endorsing this agent. In fact, as I said, the cardiologists have now started using this as a cardiac failure treatment and one of the most important cardiac drugs. And so too the renal doctors, because they're seeing these benefits even in people without diabetes. And just to put that on the proper context, this is the ADA 2021 guidelines, and these are moving every day, every year. These guidelines keep changing. So what the ADA says that if there is high risk or established atherosclerotic cardiovascular disease or CKD or heart failure, you should consider SGLT2s right there. And whereas here for the atherosclerotic cardiovascular disease, GLP-1 receptor analogs are given an equal place. When it comes to heart failure, you can see the GLPs are not there, and it's only the SGLT2. And when it comes to CKD, again, the SGLT2s are given the first place. And so they have really come to stay. And I won't be surprised if another box for NAFLD gets added because there are trials going on for that as well. Coming to the DPP4 inhibitors, they are my favorite drugs for a very long time. And the simple reason for that is that these are drugs without any side effects, virtually without any side effects. My teacher, Professor Sam G.P. Moses, used to say, fill up and feel the difference. When you go to a petrol bump, if you're using a better quality of petrol or diesel, fill up and feel the difference, he'll say. So like that, once you prescribe and forget about it, that will be the mantra for DPP4 inhibitors. You won't get a patient calling in the middle of the night saying, I've got hypoglycemia, I've got this. Even a 75-year-old person, give it. Patient has creatinine of 3, you can still give it. So for anywhere you can give that, particularly certain classes of the DPP4 inhibitors, and others you just have to reduce the dose a little bit. So again, a good durability of glycemic control and weight neutrality, low risk of hypoglycemia. They might help early. The verified trial also showed that deterioration of beta cell function can be prevented. So that's just a quick overview of the subject of DPP4 inhibitors as well as the SGLT2. And to speak on these two molecules, we have two excellent senior diabetologists, endocrinologists of this country. It's a great pleasure to introduce my two good friends, Dr. Manoj Chadda, who's a consultant endocrinologist at the PD Hinduja Hospital in Mumbai and the Hope and Care Center at Navi Mumbai. He has years and decades of teaching experience as an endocrinology teacher and is ex-faculty at the KEM Hospital. He has been trained in the use of the artificial pancreas biostat at the University of Ulm, which rings a bell for me because that's where I also got the training with the Professor E.F. Pfeiffer, the giant in that particular field. He is a past president of the Endocrine Society of India, past president of the Indian Society for Bone Mineral Research, and a member of the Asia Pacific Regional Committee of the IOF. He has several publications and both in journals and textbooks. I'll finish off the introduction of the next speaker as well, so that we can have a smooth flow after that. And it's a great pleasure for me to introduce my good friend, Dr. Neeta Deshpande, who's a diabetologist and bariatric physician from the city of Belgaum, where she runs the Belgaum Diabetes Center and the Weight Watch and Children's Diabetes Center. She's also professor and HOD of medicine at the Dental College in Belgaum and associate professor of medicine at the USMKLE International Medical Program. Dr. Neeta Deshpande is a much sought after speaker, as you all know, because she's a great orator. And her presentations deal specifically with diabetes, but also on obesity and reversal of diabetes, in which she has carved a niche for herself. She has several publications in peer-reviewed journals and textbooks. She's a past chairperson of the Karnataka RSSDI. She served as principal investigator of several clinical trials. She has received the KRSSDI oration in 2016, several fellowships and from the Royal College and from RSSDI. She's a coordinator of the consensus group of RSSDI clinical practice recommendations and many, many such laurels. So very honored to have two good friends and also two very distinguished diabetologists, endocrinologists to take this forward. And without further ado, I would like to invite Dr. Manoj Chadda to take over and give his talks. Over to you, Manoj. Thank you. You're muted, Manoj.
Yeah, sir, unmute yourself.
Yes, so I remember it was 1986 when we met in Ulm for the first time. I was coming in and you were leaving. So that was a great thing. And the friendship has gone on for the last 35 years. For the audience, I will be referring to Dr. Mohan as Mohan. No disrespect for him. He's a great person. But it's just that we've been together for so many years. So please bear with me on that part. And thank you for the introduction. And this topic is something which comes up again and again. And I'm reminded of the time. This says a decade's experience, but to be precise, 2008 was the first time when we had the advisory board meeting for a DPP4 inhibitor in India. And the general feeling after looking at the data and the price of the drug was that we are looking at a very fancy metformin. And as Mohan also mentioned that like the SGLT2 inhibitors, we did make a mistake with DPP4 inhibitors also. It has totally changed our outlook towards management of type 2 diabetes. There were times when we had to start insulin in our patients. And now with the DPP4 inhibitors, so often you will have anecdotal reports of patients being treated with these drugs and not requiring insulin for years. Anyway, that's besides the point. I think today what I will be discussing is a very brief on the epidemiology of diabetes and just one slide on the ominous octet because all of you are very familiar, but just to give you an idea of what is available in the market. A little bit on the various DPP4 inhibitors. I think the emphasis on this in this program is going to be on Glypton, courtesy Panacea Biotech, and we look at the efficacy and safety of Glypton. The crux of my talk today would be on the importance of early initiation of combination therapy, especially from data from the verified trial. And then hopefully by 22-23 minutes, I'll be able to summarize my talk. So we know that there's a huge burden of diabetes, and every year IDF comes out with some new data. 3 years ago, Mohan and his team came up with the ICMR INDIAP study, and we learned that 63 million Indians were diabetics. And within, I think, 3 years, we have gone up to 77 million diabetics. But I think the important part of this meta-analysis by Anup Mishra and his friends involving about 69 publications was not that we have a lot of diabetes, whether it's in South India or West India, but the fact that the percentage of pre-diabetes and the burden is very heavy in our country. I still remember as a student in the 70s, we were taught that 1% of the rural population above 20 and 2% of the urban population had diabetes. Today, we are talking in terms of 17%, 24%. And what is scary is the gap between rural and urban, which used to be double, is now nearly closing up. So the rural population is developing more diabetes, and probably the load of pre-diabetes is also increasing in this population. So we really need to work towards reducing this load, or at least preventing the progression. We've seen this slide time and again to emphasize that hyperglycemia comes due to various defects. So type 2 diabetes is just not high blood sugar. The various organ defects, the beta cell defects, the incretin defect, lipolysis, looking at reduced uptake at the glucose level, neurotransmitter dysfunction, increased hepatic glucose output. All in all, there are about 7-8 classes of oral antidiabetics that we keep talking about. And the various defects that we are very familiar with is the beta cell dysfunction, which probably starts off the whole thing, which preceded by insulin resistance, but leads to progressive decline of beta cell function. So that's where the secretagogues have always worked, sulfonylureas and glycides. But we have somehow over the years overlooked the role of alpha cell, and the important thing that glucagon secretion is not suppressed. So ever since a decade plus, the DPP4 inhibitors came onto the scene, we realized that DPP4 inhibitors not only are secretagogues, but they also are alpha cell suppressants, and that makes it, giving it a unique position in management of type 2 diabetes. I'm now going to be discussing about metformin and the thiazolidinediones in this talk. So we are aware of the role of GLP-1 in controlling glycemia, its effect on the beta cells, its effect on the gut, the central effects on the heart. But the important thing is that GLP-1 is metabolized within minutes by the DPP4 enzymes. And the DPP4 inhibitors inhibit these enzymes, and that's why prolong the GLP-1 and GIP, the physiological levels, for a longer time. And technically, they are divided into 3 classes, and vildagliptin and saxagliptin belong to class 1. And for those who are really interested, when you talk of class 1, they are inhibiting the S1 and S2 site on the DPP4 enzyme, whereas class 2, which contains allogliptin and linagliptin, have an extended coverage, including S1, S2, and S1 prime and S2 prime, whereas the class 3, which sitagliptin and teneligliptin belong to, have an extension called S2 extensive also. So DPP4 inhibitors have been around for over a decade, and as a matter of fact, vildagliptin was the first approved DPP4 inhibitor. All the sitagliptin came first to the American and the Indian market, and there have been, I think, huge exposure of patients, 17 million patients, and probably one of the most extensively studied DPP4 inhibitor in terms of clinical utility. The important thing is that it is nearly completely absorbed after oral administration, and food does not interfere with the absorption. The plasma protein binding is low, about 9%, and the half-life is between 1.5 to 4.5 hours. It undergoes 70% renal metabolism. There is no CYP450 isoform interaction, and most of it is eliminated via the urine. In terms of efficacy of vildagliptin and the vildagliptin metformin combination, there have been a whole number of studies. I'm just going to refer to 3 or 4 studies which are of interest to us. And I think the first one was the EDGE study, which was an open label effectiveness and tolerability study in Indian patients. And I remember, I think I just got into private practice around this time. So I remember the study very vividly. Huge number of recruitment of patients, 11,000 patients, divided into those who received vildagliptin and the comparator drugs. And the primary efficacy endpoint was to see for A1C reduction of more than 0.3% without any major side effects of peripheral edema and hypoglycemia. And the secondary efficacy endpoints was to look at, again, no hypoglycemia and weight gain, along with the efficacy of A1C reduction. And all in all, in terms of comparators, whether we're using sulfonylureas or other drugs, the primary efficacy endpoint and the secondary efficacy endpoint was met. So vildagliptin was not inferior to the comparator. As a matter of fact, in terms of A1C reduction, it did better than the comparator drugs. Another shorter study, 24 weeks, 185 patients, but divided into three groups: A1C less than 7.9%, 7.9 to 8.5%, and A1C of more than 8.5%. And at the end of 24 weeks, you would see that patients achieving a target of less than 7% was 45% in the group 1, 30%, and 16% in the group 3. So normally what it has been seen is that when you're using an oral anti-diabetic, and if the prevailing A1C is on the higher side, they do tend to bring about a greater reduction in A1C. But efficacy-wise and tolerability-wise, it was well shown in this study. Another 24-week study in combination of metformin and sulfonylurea, but inadequately controlled, as compared to placebo, there was a 1% greater reduction with vildagliptin in this set of patients. And here, as in earlier studies also, vildagliptin is being used as 50 milligrams twice a day. Multiple publications in terms of safety have come out, and really there is no doubt, as Dr. Mohan also mentioned, that its tolerability and side effect profile is like that of a placebo. One of the major issues with vildagliptin has been that it does not have a CV outcome trial, and it's for this reason that it was never sold in the US. But the European market, the Indian market, the Far East market has plenty of experience with the use of vildagliptin. And this large real-world study, 28,000 plus patients over a 12-week period using vildagliptin 50 milligram twice a day, whereas the other comparator group were the non-vildagliptin treated patients. And what was important is that the risk of hospitalization, risk of cardiovascular death, and risk of fresh myocardial infarction was significantly reduced. And the important point, again, which we always look for in a CV outcome trial, was that it did not increase the risk as compared to the comparator drugs and the placebo also. We are worried about the renal safety of oral antidiabetics, as we are very well aware that the progressive nature of type 2 diabetes, the risk of progression from stage 1 to stage 5 renal disease is very well known in our patients. And here again, using it 50 milligrams twice a day in patients with moderate renal failure group and the severe renal failure group, efficacy was documented 0.5 to 0.6% A1C reduction and no major adverse effects. As a teaching, vildagliptin, once the GFR starts going below 60, we reduce the dose to 50 milligram once a day. But here it was used twice a day. So the thing is, with DPP4 inhibitors, linagliptin, you don't need to make changes when there is a declining renal function or declining GFR. Sitagliptin, you go down to 50 and then 25 milligrams. Whereas with vildagliptin, you go down to 50 milligrams, and with saxagliptin, it's 2.5 milligrams. But where accidentally you are giving an extra dose, there is no major problem in these diabetic patients. So all in all, to summarize the role of vildagliptin in management of type 2 diabetes, you can see that there is some incidental evidence of beta cell protection, but the fact is that there is durable glycemic control. Studies from up to 4 years are there. Weight neutrality at the best, and then there are anecdotal stories of weight loss in some of these patients. Because of its incretin story, the risk of hypoglycemia when used with anti-hyperglycemic drugs is very less, and there is no evidence of increase in cardiovascular risk. So all in all, a good drug to use, and as Mohan did mention in the introductory part of his talk, that you can prescribe it easily to any age group, any comorbidity, and just forget about the side effects that might come out along the way. So the question that comes up is, why initiate vildagliptin early in type 2 diabetes management? And this answer came about 2019 after a 5-year trial called the Verify trial. And what it signifies is the vildagliptin efficacy in combination with metformin for early treatment of type 2 diabetes. And a little brief on this trial, although I'm sure all of you have heard about this, is this was basically 2,000 odd patients who were divided to receive either, so there was a run-in period with metformin, and then they received either vildagliptin in one arm and placebo in the second arm. And the idea was to see the durability of the combination therapy and at what stage that patients start failing so that they needed an additional drug or they needed insulin. And this is the study design, a run-in period of 3 weeks, metformin up to maximum of 1,500 milligrams a day, or what was tolerated, so between 1,000 and 1,500 milligrams a day. And then in the 1:1 division, blinded, either the patients received vildagliptin 50 milligram twice a day or placebo twice a day. So they were divided into 3 periods. The first period was the 3-month period. Then that was the second period where actually both the groups ended up receiving vildagliptin. So here, combination therapy to begin with, continued with the combination therapy, metformin alone, and then given combination therapy. And the third part was if the patients started failing, failure meaning A1C going above 7%, then they were given basal insulin. To cut a long story short, what was important is when vildagliptin and metformin was started at the beginning, the initial failure was around 43% as compared to 62% in patients who received only metformin. In other words, the A1C started climbing up above 7% when metformin was used alone in 62% of the patients. And the median period when this was happening was about 36 months, whereas with the combination therapy, the calculated median was 61 months. That was going beyond 5 years, whereas this study was for actually 5 years. So this was a calculated period of 61 months. The important thing with the combination was that the relative risk for treatment failure was reduced significantly, 49%, consistently lower A1C over a 5-year duration of the study, and greater proportion of patients reached A1C of less than 7, less than 6.5, and less than 6%. So all in all, I think this is something which we have known, and I've heard Mohan speak so often of going early aggressive therapy. We've heard about the UKPDS legacy effect and the metabolic memory from DCCT. But this study probably in a real life study has shown that we should go aggressive from the beginning. And those are the conclusions again, that early combination gives a greater and durable long benefits, reduces the risk of initial treatment failures, and maintains the A1C for a pretty long period of time. Here it was 5 years. Now within this study, there was a subgroup of analysis called, which was involving patients less than 40 at diagnosis. They've been called as young onset type 2 diabetes. And those who develop diabetes after 40 were called as the old onset of diabetes. And the important thing was in young onset diabetics and later onset of diabetics, the primary endpoints still remain the same, that irrespective of the onset, the age at onset, going for combination therapy help achieve both the primary and the secondary endpoints of reducing the failure. And for those who are interested, the primary group I saw Dr. Mohan's name also in that, where he's written a summary on insights into verified trial. Yeah, so this is the sort of summary of the young onset diabetes. Again, that early combination led to failure at the end of median of 61 months, whereas when you use metformin alone, they had earlier onset of primary and secondary failure. So probably with the verified trial giving so much of real world evidence, the ADA and the ESD has changed their approach. Earlier, if you remember 2005, 9, 10, they used to talk of start with one drug, wait for 3 months, then go for a second drug, so on and so forth. So now, ACE has always been talking about it, and the ADA also now recommends that you can start with 2 drugs right at the beginning. So to summarize, I think the important points that I want to make is that DPP4 inhibitors have made a huge change in the approach and management to type 2 diabetes. I know last 2 years, there's been a lot of real world good evidence regarding the efficacy, the safety and the benefits of SGLT2 inhibitors. But I think in regular practice, the role of metformin, sulfonylurea, DPP4 inhibitors, and to some extent thiazolidine is very much established. So we should work towards reducing the burden of diabetes in our country. Early detection and diagnosis is very important. Engaging our patients and the relatives, close relatives in the management is important. Initiating aggressive therapy at the beginning, not waiting and watching and seeing what happens. Monitoring patients, again, empowering them to be a part of management and not just giving instructions 1, 2, 3, 4. Regular investigations, the importance of A1C, eye examination, urinary albumin creatinine ratio, again has to be stressed. And probably with these multiple interventions, we will be able to at least reduce the progression to some extent of type 2 diabetes, reduce the burden of complications, and then overall reduce the morbidity and mortality associated with type 2 diabetes. Thank you very much. I'm going to stop sharing and hand over the proceedings back to Dr. Mohan.
Thank you, Manoj, for that very, very clear exposition. What came out very clearly is that the DPP4 inhibitors in general, and vildagliptin in particular, are very effective in Indians. I saw that data which you showed on top of sulfonylurea and metformin, and there was a 1% reduction. We had shown the same thing with sitagliptin earlier. And we found it, people found it difficult to believe why when sulfonylurea and metformin have failed, how can a mild drug like this produce? But that's because it has different mechanisms of action, number one. And number two, we know increasingly now that the Asian Indian phenotype is different. For example, in the West, in the US, they call this drug as a placebo, the DPP4 as a placebo. They only get 0.3, 0.4% reduction. Why should we even use this drug? And it's quite expensive there, by the way, because Vilda is not there, and Sita and Lena are both quite expensive in the US. So they have virtually stopped giving up on this drug. But in India, from the very first trials that we did with sitagliptin and later on with Vilda as well as with Lena, we have shown that this group of drugs, and the same thing was shown in Korea as well, that Asians seem to respond better. And our good friend Dr. A.K. Singh has done meta-analysis on this and systematic reviews. Several have been done. And all of them show that Asians respond better to the DPP4 inhibitors. And therefore, I think these drugs, given their safety, given the fact that now they become affordable also with the Vilda going off patent, they really are very useful drugs. And there's, as you rightly said, you can just use it and forget about it. And therefore, you don't worry, the patient nor the doctor needs to be worried about this. So that's a very clear view on DPP4 inhibitors and vildagliptin. Now let's move on to the next topic, which will be on the SGLT2 inhibitors. I've already introduced Dr. Neeta Deshpande. She's a consultant diabetologist from Belgaum, very well accomplished, very powerful orator. And she's going to talk about the other new molecule, which has been making creating a lot of waves all over the world and in India also. That is the SGLT2 group of drugs, and she'll be talking on that with particular emphasis on dapagliflozin. Once that is over, we already start getting a plethora of questions and flooded actually with questions already coming in from doctors all over India. So we'll wait until Neeta finishes, and once it's over, I'm sure we'll have a very interesting discussion and the question and answer time after that. So over to you, Neeta.
Thank you so much, Dr. Mohan, sir, for that very warm and kind introduction. And at the outset, I would like to thank Panacea for giving this opportunity to me to be on the same platform as Dr. V. Mohan and also my good friend, Dr. Manoj. So I shall start by sharing my screen. Right. So we want to talk about dapagliflozin, but first a little about SGLT2 inhibitors. I think never in the history of anti-diabetic medication has
Can you make it full screen, Neeta?
I will. Yes. So as I was saying, I think there is no other class of drugs in the history of anti-diabetic medications that has taken the whole world by storm. And the results that we've seen of the drug molecules across this entire class has been. So SGLT2 inhibitors in general and DAPA in particular.
We are losing you on and off. Neeta. We are not able to hear you. Do you want to go out and come back again?
No, sir, we will keep remain as it is. So if she's having connectivity issue, it will get restored. After Pallavi can call ma'am and check it out.
Yeah.
Yeah, that is technology. You know, sometimes you get stuck up. Yeah. So,
Talk about the rationale for early risk management. How can we use this drug early on in the disease and bring down the risk? Second, the place of SGLT2 inhibitors in early diabetes therapy and the advantages of this particular class of drug. And then a little about the landmark clinical trials that have been done with dapagliflozin, and then the summary. So just to give you a background, we know that early initiation of glucose lowering therapy in patients with type 2 diabetes to achieve glycemic control is very important to reduce microvascular risk and also cardiovascular risk. We have enough studies to tell us that. And clinical studies have all indicated that if you achieve glycemic targets early in the disease, it is likely to have the greatest effect on preventing micro and macrovascular complications, the legacy effect or the metabolic memory that we talk about. So that is very, very well known. And to this end, SGLT2 inhibitors have proven to improve glycemic control, reduce not only heart failure, but also CKD progression, reduce CV risk factors. It works on weight, so obesity also. It reduces blood pressure, so it works on hypertension as well. And they have a low risk of hypoglycemia. So this is the background we have of SGLT2 inhibitors as a class. Now for the rationale of early risk management. So it's very important that we start reducing risks of diabetes and its complications as early in the disease as possible, because that is what is going to reduce mortality and cause longevity in our patients. So we have these landmark trials such as the UKPDS, we have the DCCT, the ACCORD trial, all of which, even after the study stopped and then the analysis was done on the patients again, after the study had stopped, showed that if you manage them intensively in the beginning, at least the UKPDS, it still has the effect in terms of risk of CV events later on, if you do it in newly diagnosed. And ACCORD trial also showed that risk of mortality increases as the A1C keeps on increasing. And that is the reason that early management is required. Because if you start way too late, because ACCORD was patients who were already very high risk, who already had some problems. And that's why it has been shown that if you start early, only then do you get the benefit of early glycemic control. So in patients with a shorter type 2 diabetes duration, there's no atherosclerosis yet, or at least not significant, intensive glycemic control reduces the CVD risk. Whereas in older or frail patients who've had diabetes for a long time, and who probably also have advanced atherosclerotic disease, the risk associated with intensive glycemic control may exceed the benefits like you saw in the ACCORD trial. So early initiation with SGLT2 inhibitors. So how is this going to work for our patients? So early use of combination therapy, if you use it in newly diagnosed patients, it has been shown to reduce the progression of atherosclerosis, apart from, of course, reducing the the blood sugar. So glycemic control is there. But here we are worried about atherosclerosis. So compared with conventional therapy, which is like stepwise, so if you had to use aggressive therapy right in the beginning, you'd probably be doing better in terms of CV risk for your patients. That is why for patients whose A1C is more than 7.5 at diagnosis, the ACE guidelines recommend starting on dual therapy with metformin and another class of glucose lowering therapy, such as the GLP-1 receptor agonists or SGLT2 inhibitors, which are the preferred combination to use. And for patients with an A1C of more than 1.5% above goal at diagnosis, the ADA and EASD guidelines also recommend first-line treatment with a dual combination. This slide has been shown many times, and I'm going to show it to you as well. Latest ADA 2021 guidelines talk about using SGLT. Now, this is a very important thing because this is for the first time that the guidelines have recommended the use of a drug regardless of the HbA1c, which is it's an important milestone that you look at the risk factors and start a drug and not just the glycemia. So A1c is irrelevant if these risks are present. And this is what the latest 2021 guidelines has told us. So what is this being the background that early therapy or early for reduction of risk factors and for CV benefit, when we know that early aggressive therapy is important, in that context, what is the place of SGLT2 inhibitors? So this we know now, this has been shown, and here it is that once you've used metformin, you just assess the risk of ASCVD, CKD, or heart failure. And if you find that this indeed exists, then you are supposed to use SGLT2 inhibitors, especially if it is more of heart failure and CKD. Here you have a choice. You can use a GLP-1RA or you can use an SGLT2 inhibitor. But when it comes to heart failure and CKD, clearly it is SGLT2 inhibitors which comes out the winner, and this is supposed to be added regardless of the baseline A1C. So that is how important it is to use SGLT2 inhibitors much earlier in therapy. So now this tells us about the additional advantages of SGLT2 inhibitors. So as Dr. Mohan sir had already told us, it started off as an anti-diabetic agent. And we started using it as such, and then its other effects, its pleiotropic effects came to the forefront, and we realized that it does far more than just reducing the blood glucose. It's a very versatile drug, and it can do so many things, and that is the reason that it has the labeling that it has today. So it has beneficial effects in patients with atherosclerotic disease. It has beneficial effects in reducing heart failure, hospitalization, as well as worsening of heart failure, as you will see. And it also has a good effect on the kidneys. It reduces the progression to end-stage renal disease in type 2 diabetes patients. And most importantly, it can do all of this without the excessive risk of hypoglycemia. And something that we want for all our patients, it promotes weight loss and controls hypertension. When you look at this slide, which is all true, it looks like you found the holy grail for the management of type 2 diabetes, because it does so many things that so many other drugs can't do. It's like buy one and get several free, so it's something like that. So that is what I would put SGLT2 inhibitors as. And that is the reason that I'm going to take you through some trials. But before I take you through the trials, let us also look at the advantages of SGLT2 inhibitors in different populations. Because we know that type 2 diabetes doesn't come in isolation. It comes with so many problems and challenges. So many of our patients are obese. For them, this is a drug to nicely kickstart the weight loss. The weight loss is not huge, but it doesn't make you put on weight. Instead, it makes you lose some weight. And some people do lose far more than the usual, which is like 2 to 4 kgs, but some patients lose more. In the elderly, so it causes effective lowering of the blood glucose, the body weight as well, and the systolic blood pressure. You know that hypertension is an accompaniment with almost 60 to 70% of our type 2 diabetes patients. Third important thing is the renal impairment. It has synergistic effects with antihypertensive therapy, and it reduces the risk of albuminuria and proteinuria in CKD patients, which I'm going to show you shortly. So these different or special populations, let me call them, even in these people, SGLT2 inhibitors have an advantage. So the glycemic advantages of SGLT2 inhibitors, if we just stop to think about it, as a monotherapy, there is a significant reduction in A1C and body weight. If you combine it with metformin, also you have good reduction in A1C, fasting, BP, and body weight. If you use it with sulfonylureas, then also you have the same kind of effect. Only thing is you need to be careful when you're using it with sulfonylureas, because the risk of hypoglycemia may be a little increased because of the sulfonylurea being there. And then combination with DPP4 inhibitors, it has complementary glucose lowering effects. So all the effects, or the good effects of DPP4 that was shown to you by Manoj in the previous talk, they are complemented, and there is a synergistic effect in reducing A1C, fasting, and PP if you had to use these SGLT2 inhibitors along with it. And if you use it in combination with PIO, you can still, you have all those same benefits. And if you combine it with insulin, you have significant reduction in A1C, fasting, and body weight. But here again, a word of caution, the risk of hypoglycemia is there because insulin is being used along with it. And you can use it in combination with GLP-1RA. So it is like salt. You need salt for everything. So you use SGLT2 inhibitors. You can use it with anything and everything. It will enhance the taste. It will enhance your effect that you have with your other anti-diabetic agents. And therefore, what it means is that SGLT2 inhibitors can be used in all stages of type 2 diabetes. And why is this so? This is so because it bypasses the pancreas. Its method of action does not use the pancreas, and that is the reason that you can use it all through. And it this independent action of it makes it a viable option, a viable drug choice to be used with anything. So we know how it does this. I'm not going to go into the details. This is for heart failure. We know that this is one of the drugs that the cardiologists are just grabbing. They have so many drugs, but they've found this to be like, you know, a panacea. And I'm doing a panacea talk. That's why I'm using the word panacea. So this seems to be like that. So what it does is it stimulates natriuresis, osmotic diuresis, improves systolic and diastolic function, endothelial function. It improves myocardial autophagy, reduces blood pressure, weight, and of course, glucotoxicity is also reduced. So these are the potential mechanisms of improved cardiac function when you use SGLT2 inhibitors. So this is a brief history of when the drug started to be used, and we know that canagliflozin first came out in 2013. It was approved in 2013, and ever since then there's been no looking back. This was about 8 years ago. As I said, I don't think there's ever been a drug that has been in use for just such a little amount of time and yet found its way into all the guidelines of the world for use, and that was so high up in the hierarchy of usage. And that is because of the wonderful effects it has shown in the various trials. So let's now come down to dapagliflozin. So of course, just like all the other SGLT2 inhibitors, we know that dapagliflozin also acts at the proximal convoluted tubule, and it increases the urinary glucose excretion. So that is how it acts, because it selectively inhibits SGLT2 in the renal proximal tubule. And by doing this, by excretion of glucose in the urine, it causes a reduction of the blood glucose. Now, if you had to look at some of the differences between the all the SGLT2 inhibitors that we have now, the first three are the ones that we have available in India. They're all oral. And of course, you're all well aware of the drug dosages of this. And this is the bioavailability. And you can see here that of the three that are available, it looks like dapagliflozin has a better bioavailability than the other two. And the time to peak action is more or less the same for all of them. Some of the other differences are about the way it is excreted and the half-life. And you can see here that the contraindications are exactly the same for each and every one of them for the entire class, and that is hypersensitivity, severe renal impairment or dialysis, pregnancy or breastfeeding. So this is how it is. And all of them actually have no significant interaction with the other drugs that we are using. So this is across the board, all SGLT2 inhibitors seem to be very similar in this. What about effectiveness and safety? You can find subtle differences in this. And of course, the maximum lowering is around 1% and more. And dapagliflozin in studies has been shown to have a slightly more glucose lowering effect than the other two that we have in the market today. Now, as far as the CV and renal outcomes, this is what we are concerned with. This is the focus not only of today's talk, but it is the focus of attention of these drugs. So there is a significant reduction in cardiovascular death with empagliflozin. And of course, hospitalization for heart failure is a class effect. You will see a reduction in the relative risk of hospitalization for heart failure across the board for all of the SGLT2 inhibitors, and so also dapagliflozin, which causes significant reduction in CV death or worsening of heart failure or hospitalization for heart failure. The adverse events that are there, if you had to compare them, all of them may cause genitourinary infections. We know all about that. And hypoglycemia is not really there across all this, across the board for all these three drugs, other than if you combine it with sulfonylureas or insulin, as I mentioned to you earlier. However, it appears as if there is a slightly lesser risk for hypoglycemia with dapagliflozin if you have to compare it with canagliflozin. So these are the actual differences. And of course, for the renal outcomes, dapagliflozin scores very high because you have a dedicated trial for the renal outcomes with dapagliflozin. So that is the important thing. So there's a significant reduction in sustained decline in the estimated GFR of at least 50%, end-stage kidney disease or death from renal causes by 44%. So if you take the renal composite, dapagliflozin scores very, very well when it comes to reduction of renal events in the future. So the dapagliflozin approved indications in type 2 diabetes, heart failure, and CKD is what we are going to look at. So in type 2 diabetes, it has been approved to be used as an adjunct to diet and exercise to improve glycemic control. And as I already showed you in the guidelines, it is also used to reduce the risk of heart failure in people of type 2 diabetes who have established CVD or CKD or multiple cardiovascular risk factors. What about heart failure? Well, to reduce the risk of CV death and hospitalization for heart failure in adults with heart failure with reduced ejection fraction has been shown. And this is regardless of whether diabetes is present or not. So it has received attention because it has been approved to be used even without diabetes for heart failure. And the same for CKD as well. It has been used to reduce the risk of sustained eGFR decline, end-stage kidney disease, and cardiovascular and renal death in adults with CKD. And for this label, it has been approved by the US FDA in 2021, that is this year. So we know it comes as 5 and 10, and this is the recommended starting dose is 5 milligrams taken in the morning with or without food. It doesn't really matter. And it can be increased to 10 milligrams once daily if you require additional glycemic control. So let's now look at some of the evidence quickly about the clinical trial with clinical trials with dapagliflozin. So if you this study that I've shown you here is in drug-naive Asian patients with type 2 diabetes, and it's a randomized blinded prospective phase 3 study where about 400 participants were randomized to receive placebo, 5 or 10 milligrams of dapagliflozin, and it was a 24-week study to look at the mean change in the simple study just to look at the glycemic control, the A1C reduction in 24 weeks, a typical efficacy study. Secondary endpoints were fasting and 2-hour postprandial. And the conclusion you can see very well here, A1C had reduced by 1.1%, FPG by 31.6 and PPG by 54.9. So both 5 and 10 demonstrated clinically and statistically significant improvements in A1C after 24 weeks of treatment. Now going to the important study, and that is the DAPA heart failure study. It's a seminal study. It's a kind of a game changer study. And this was a phase 3 placebo-controlled study conducted in 4,500 and odd patients who had an ejection fraction of 40% or less. And mind you, they were both diabetics and non-diabetics in this trial. And they were randomized to receive dapagliflozin at a dose of 10 milligram once daily versus placebo, in addition to the recommended therapy. And what you see here is that they were looking for a primary outcome of a composite of worsening heart failure or cardiovascular death, and a key secondary outcome of a composite of hospitalization for heart failure or cardiovascular death. Here the slight difference is there. This was worsening heart failure. This is just heart failure. So they had 4,744 patients. They were randomized to DAPA or placebo, as you can very well see over here. What did the results show? The results showed that there was a 26% reduced risk of cardiovascular death. Now, this is huge, or hospitalization, or an urgent visit resulting in intravenous therapy for heart failure as compared to the placebo arm. Additionally, there was a 30% risk reduction of hospitalization due to heart failure. So you can see here, both for the primary outcome and for the secondary outcome, respectively, there was a 26% and 30% risk reduction, which is very, very, very relevant. And that is why it has found its way into all the guidelines. So this was the DAPA heart failure trial. Now the DAPA CKD trial, again, 4,000 and odd patients, and they took, this was also a double-blind placebo-controlled multi-center trial. And here they took people who had a GFR between 25 to 75, okay, and a urine albumin to creatinine ratio of 200 to 5,000. So these were clearly patients who already had nephropathy of some degree. And the primary outcome for this study was first occurrence of any of a decline of at least 50% in GFR, onset of ESKD, and which was confirmed by a second measurement. This is what they did, the GFR, or death from renal or cardiovascular causes. So this was a composite primary outcome, and secondary outcome was again a sustained decline in GFR of 50, end-stage kidney disease, death from renal causes, a composite cardiovascular outcome, which was defined as you can see on the screen. So they, as I said earlier, similar kind of a design, 4,300 patients randomized to DAPA or placebo to look for primary and secondary outcomes as outlined in the screen. What were the results? One, the risk of decline of at least 50% in estimated GFR, the onset of ESKD, or death from renal or cardiovascular causes reduced by 39% in the DAPA group as compared to placebo, and the risk of composite of a sustained decline in the estimated GFR of at least 50% ESKD or death from renal causes reduced by 44%. 39 and 44% risk reduction is very, very significant. And the risk of composite death from cardiovascular causes or hospitalization for heart failure, this was also studied, though it was a CKD trial, and that was reduced by 29%. And that is why this study is quoted so frequently, and it is one of the important trials of our times, where it shows you that you can actually retard kidney disease once it has occurred. So, to put it in a nutshell, dapagliflozin causes significant reduction in the risk of a composite of a sustained decline in eGFR of at least 50%, ESKD, or death from renal or cardiovascular causes in CKD patients, regardless of the presence or absence of diabetes. Both DAPA CKD and DAPA HF had a population which did not have diabetes. So again, coming back to a comparison, if you look at this, you find that dapagliflozin, as I said, has a slight edge over the others in terms of glycemic efficacy. Oral bioavailability seems to be a little more, risk of hypo little less than CANA, and renal protection has been proven very, very well with a significant decrease in the decline of eGFR and cardiorenal deaths. and cardiovascular benefits have also been seen with dapagliflozin when you compare it to the other SGLT2 inhibitors. What about the safety of dapagliflozin, side effects and management? Well, we know that female genital mycotic infection, UTI, are there, but they affect only 5 to 10% of users, especially premenopausal women. And vast majority of these cases, and we've seen this in practice as well, they're mild and require only a single standard antibiotic treatment, and the patients can be resumed on the drug or continued on the drug. Lower rates of genital infection are seen in men, of course, and it rarely leads to drug discontinuation, fortunately. And I have been on this trial, I have been on EMPA-REG, I have been on Canvas as a principal investigator, and we've not really, we've had mycotic infections, not that we've not had them, but it has rarely resulted in the discontinuation of the drug. As far as UTI is concerned, age greater than 65, female gender, history of recurrence, these are the risk factors. So you have to weigh your pros and cons when you are going to use this drug. Of course, most of these infections are also mild to moderate, but you have to be vigilant. And again, for this reason also, the drug discontinuation is pretty rare. So that is the side effect profile. So the key points with dapagliflozin are that amongst all the other SGLT2 inhibitors, if you look at the class, it has maximum efficacy in reducing the A1C, lesser risk of hypo than Cana, maximum oral bioavailability, significant renoprotection in CKD patients, and significant risk reduction in cardiovascular death and hospitalization due to heart failure, and it has a good safety profile. So to summarize, early risk management with agents having clinically proven benefits in reducing the heart failure, CKD, and ASCVD or their risk factors is of paramount importance, as all our studies have shown us. SGLT2 inhibitors offer effective glycemic control and reduce cardiovascular death, heart failure, hospitalization for heart failure, and progression of CKD to ESRD. The ADA 2021 guidelines, therefore, recommend SGLT2 inhibitors as the preferred treatment in patients with high risk or established CVD, congestive heart failure, or CKD early in the course of type 2 diabetes. And therefore, looking at the fact that I've shown you all the data with bioavailability, etc., it looks like DAPA is a better option for maximum A1C reduction, less risk of hypo than at least Cana, and significant cardioprotection and renal benefits. Of course, many of these effects are class effects, but if you had to tease out the differences, I have shown you some of the data. So thank you very much for your attention. I shall stop the sharing now.
Thank you, Neeta, for that very neat and crisp overview of SGLT2s as well as DAPA, gliflozin. So we have now the evidence for one class of drugs, DPP4 inhibitors, and the other SGLT2 by two speakers. Now, before I go into the questions, I mentioned earlier that we had numerous studies which showed that the DPP4 inhibitors were more effective in Asians and in Indians. Last year, one of our PhD students who actually works in Dundee, Scotland, Shushima Gan, she is working on the ethnic differences in different in the potency of various anti-diabetic drugs. And she looked at the DPP4 inhibitors, she looked at SGLT2s, and she looked at GLP-1 receptor analogs. She took Asians because working in the UK, she could not separate out South Asians from other Asians. So she just took, and some of the papers are not mentioned whether it's South Asians or, so she took all Asians. And what, not surprisingly, she found that the DPP4 inhibitors were more effective in Asians. So we confirmed that. But the new finding which came up from that particular study is that SGLT2 inhibitors had a much better effect in Asians compared to non-Asians. In that particular study, now since DPP4 inhibitors had a better effect, but expected the GLP-1 receptor analog will also have a better effect. But surprisingly, in that particular study, we didn't have any difference between non-Asian, that is Caucasians, white Europeans, compared to Asians. But that may be because only 3 studies in Asians looking at the differences, and it was not powered properly. So as you get more studies on GLP-1, it'll be interesting to look at oral sema when it comes, how it behaves. So it looks as if some of these drugs at least seem to be doing better in Asians and in Indians, and therefore I won't be surprised that some of those A1C reductions which you showed is actually better in our group compared in our Indians compared to the white Caucasian. So I thought I'll just raise that. Now again, just because both of you have he is talked on DPP4 and you have talked on SGLT2, doesn't mean that I cannot cross over and ask questions to other of you. You both practice diabetology, and so it's just for convenience it's divided that way. But anyway, I'll start with the first question on DAPA, and I'll ask that to you, Neeta. Surprisingly, the number of people who have asked this particular question is Dr. P. Sai Shekhar from Assam, Dr. Nageshwar Rao from Andhra Pradesh, Dr. Prasad Babu from Andhra Pradesh, Dr. Tilak KVG from Andhra Pradesh, Dr. G. Harsha from Andhra Pradesh, Dr. G. Yugandhar from Andhra Pradesh, MP Yadav from MP, Rajeshwar Singh from MP, Dr. Arshad from Kerala, and Dr. Ranjana Bhatt from Delhi. All of them asked the same question about the OD dapagliflozin. Is repeat doses of dapagliflozin better or OD dose? I don't know what they mean by that, because I think DAPA is an OD dose. So I don't know what they mean by
and I've
doses.
not come across actually any studies that have used dapagliflozin twice daily. All the studies that
I was wondering whether they're mixing it up with Wilda and asking, because now Wilda OD has come. So probably both of you can answer that. Let's forget, DAPA is an OD drug, so I don't think the question arises. And there's no question of splitting the dose or anything like that. But as far as Wilda is concerned, the OD preparations, the sustained release has come. So how will you answer that, Neeta, and how will you answer that, Manoj? What they're asking is, where do we use OD and where do we use? With Sita, there was no problem. Lina, there's no problem because it is an OD dose. With Wilda, it was a BD dose. Now they made it an OD dose. So now they're asking where to use that. So what would be your answer?
If you ask me, it depends upon what the patient A1C is at. For example, if I'm going to be using metformin twice daily and vildagliptin also 100 milligram dosage, I would rather split it, because I would anyway be giving metformin twice. So on a practical basis, I would just split it because it's meant to be used that way, and I would give it twice like that. There are those kind of patients who are very good fasting, who don't need any drug at night and who need a drug only in the morning. In those kind of cases, yes, I may think of a Wilda that is sustained release and maybe pair it with metformin and give it only once in the morning and be done with it. But most cases, if I'm giving metformin twice and if I had to give vildagliptin, I would just split it.
Okay. Manoj, how will you respond?
So, if you look into the history of vildagliptin, the initial trials were using 100 milligram once daily versus 50 milligram twice daily versus placebo. And, for some reason, the 100 milligram daily dose, single dose, the risk of liver problems were much higher in that. And that's the reason why it never got into any further development. We also know that the DPP4 inhibition with a single dose of vildagliptin is not to the same tune as with sitagliptin or with linagliptin. You would expect at least 85% inhibition for the 24 hours.
Yeah.
So with that in mind, I think we started living and prescribing this 50 milligram twice a day. There was also some signal of the QTC prolongation with that once a day dosage. So that's why, I did have a slide in my talk on the once a day preparation, but I thought we'll discuss it. And I'm also going to, after I finish, I'm going to look at Mohan for an answer also. So yeah, the Indian pharmaceutical industry is great when it comes to, what we use in Mumbai, Jugada. They find a way around, because there were others who were saying, oh, once a day is better than twice a day. So let's get something on vildagliptin also. So yes, I have sparingly used it. I am still comfortable with that twice a day for one, the DPP4 inhibition. And secondly, as Neeta said, because very often we end up combining it with metformin, then why to change that standard drug that has been around for so long? So that's the whole thing. And I'm really looking forward to some, safety data. I'm not worried about the efficacy part. Once we have a little more confidence, probably we can go all out. But as of now, twice a day is what I prefer over once a day.
Same.
I think I also tend to agree, because you've been using it now, and now when it's going off patent, why change the whole thing and make it like a, I thought it was a bit strange on the part of the industry too. But the thing is that I think even the innovator is now coming with the 100.
Yes, yes.
All these years when they had the patent, they didn't think of it. But now the innovator also, we also got 100 milligram OD, you know. So I was smiling to myself saying, what are you guys doing all these years? You know? So anyway, so I mean,
yes, sir. I would like to add one thing here. This is regarding the AUC of the drug over 24 hours, and what Dr. Manoj Chadda stated that earlier observation, and this of almost 14 years of the use of DPP4 inhibitors, and vildagliptin has shown that that toxicity what they expected of the peak of the concentration, which is causing cardiovascular toxicity, which is not there, which reflect into changes of ECG. And that confidence which has got built over safety profile has shown that it do not have the high concentration drug, and that is for momentarily. So they are maintaining that peak not to go immediately, and they are flattening the peak of the curve, and therefore the drug is available over 24 hours. So pharmacokinetic properties modification is really essential. Earlier, modifying technology of drug release for vildagliptin was not possible. Over the period of time, that pharmaceutical formulation and novel drug delivery system, ingredients and technology keeps on changing. So that's why it is possible now.
Yeah. I was also going to respond to Manoj that probably it is the new technology of releasing it slowly. And I suppose if it release it slowly, the QTC prolongation and all that may not be there. But I suppose you leave it to the physicians. If the drug controllers approved it and it's available in the market, people who want, and then there are people who don't like to take too much of pills, and therefore an OD drug as compared to BD drug. There are some people who are fastidious about that. Others don't care. So I think it's like having more choice of cars. You know, if you have more cars, the better, and then you choose whatever you want. So I don't think that's an issue. It's rather an advantage. A question to Neeta, to you. Can DAPA be given in a 10-year-old child, to 10-year-old children? Dr. Ranji Bahadur Singh from Haryana wants to know.
I don't think we have data for that. All the clinical trials have been 18 and above. So we don't have data for use in pediatric age group. If some studies may be there now in type 1s on ongoing, then I don't know about them. But as of now, no.
He didn't say type 1, he just said 10-year-old. So it could be a very obese type 2 or something.
Yeah.
But even there, I don't think it's actually.
No, we don't have the, no approval also.
Be hesitant to use it given the DK. And some of these children, even type 2s can present with ketosis and all that. So the last thing you want is diabetic ketoacidosis. Right. And in type 1, we know abroad it is used very extensively in the US, but there's so much of obesity and all that they give that. But they accept that 5% will go into DK, and I'm not able to accept that 5% DK. 100 people you give and 5 are going to go into DK. That's not an equation which, for my mind, permits me to accept. So I don't use it here. But abroad they use it. People like Satish Garg and many others, Paresh Dandona and others have used it, and they swear by it. So anyway, maybe we'll do it later, but not right now. Now, I'll ask Manoj now. Impact when Vilda and DAPA are recommended together in a single patient. I think we have discussed that, but would you like to combination therapy?
Yeah, I think, DPP4 inhibitor with an SGLT2 inhibitor combination is a very interesting combination, because you have DPP4 inhibitors, secretagogue function, the alpha cell suppression, SGLT2 inhibitors working on the tubules and causing increase in glucagon because the risk of decay. So combining the two has more than one benefit. And I think we have been using it in practice as separate drugs, and the last couple of years as fixed dose combination, and it seems to work better than the two separately.
Yeah. And also, if you already have metformin there, I think all the 8 of the ominous octet, which both of you showed, is going to be covered. There's virtually nothing left there in that. So I think that's very good. That question was from Dr. Sunil Barua from Assam and Dr. Muttamil Selvi from Tamil Nadu. So, Neeta, you mentioned UTI, and you mentioned it's more in females, and it's not all that much, and so on. So, what should be the recommended protocol for UTI associated with dapagliflozin? This is from Dr. Mannan Mehta from Mumbai and Dr. Rao from Karnataka.
The usual protocol that was followed even during the trials, and even what we practice now in regular practice, is that if it is mild, we do not discontinue the drug, but we give the antibiotics if it is a UTI, and antifungals if it is a mycotic infection. And if it resolves, then the drug is continued. If we find that it is very severe, we discontinue the SGLT2 inhibitors, treat the patient, and after a period of time, try to re-challenge. Even on re-challenge, if this recurs again, then we have to give it up. Yes.
Yeah, there is a small group of patients who simply cannot tolerate any of the SGLT2s. That's very clear. So, Manoj, next question for you is a strange question from Dr. S.K. Shamim from West Bengal. Recommended doses for Vilda and DAPA in CKD and pancreatitis patients.
Pancreatitis.
So let me take the CKD thing first.
Oh, CKD with pancreatitis.
Oh,
I don't know. It's I think it's CKD and pancreatitis.
So CKD, Vildagliptin 50 milligrams single dose is the accepted dose. In terms of dapagliflozin, I think up to EGFR of 30 is where I would be using it. If I go below that, it's off-label. So for today's discussion, let's stick to 30 ml.
30.
And then we can use the full dose there, 10 milligrams.
Yeah.
In terms of pancreatitis, I think the safe answer is I will not use it.
So, obviously. You have already answered this, Neeta, but is DAPA good for non-diabetic heart failure? Dr. Sarfraj Majid.
Yes, it is used because as was seen in the DAPA HF study, it has been useful and it is being used. And it has received a label for that as well.
Perfect.
Yeah.
Manoj, just a little tricky one for you. Key difference between Vilda versus teneligliptin versus sitagliptin?
I have an easy answer for that. So when it comes to efficacy, I think you don't have much to choose between. Whatever your favorite is, you can go ahead with it. When it comes to safety also, probably years of experience with sitagliptin and vildagliptin may give you a little more confidence. But however, now we have been using teneligliptin, the single dose, for a couple of years, and we're quite happy to use it. I don't have much experience using it twice a day or even in a higher dose, because then you start worrying about the QT prolongation. But 20 milligram teneligliptin, 100 milligram sitagliptin, and 100 milligram vildagliptin probably would compare.
So there is this question about COVID and the use of Vilda. You can talk about Vilda, and Neeta, you can talk about DAPA.
So if I were to go first, I think COVID being managed at home, no need to change any of the anti-diabetic drugs. COVID being managed inpatient, not too sick, you can still very safely continue the DPP4 inhibitors.
Probably the safest of all.
Yeah. And the ICU setting is going to be a different ball game. Let's not go into that because the intensivist is going to manage with IV insulin.
They'll be on steroids anyway.
Yeah, let's not go there.
Right.
Neeta, want to talk about the DARE trial?
Yeah, as far as, I was happy to have been a co-author on a study on an article that we published with Dr. V. Mohan sir and group on use of these drugs in COVID. Very recently, we came out with that. And we've also clearly, it's been mentioned in that, very much like what Manoj said, that if the patient is got very minimal symptoms or no symptoms at all and is being under home isolation, there is absolutely no need to change any anti-diabetic therapy, not even SGLT2 inhibitors. They're quite safe. However, if they are going, you have to watch out for dehydration when it comes to dapagliflozin, especially even if they are home isolation. If hydration cannot be ensured, then maybe you might have to withdraw, but otherwise there is no need to withdraw this drug even in COVID being treated at home. In the hospital, probably it would be a wise decision to take it away because patient could be on steroids, could be on different kinds of IV fluids and all of that, and that's a different ball game altogether. But home isolation, I don't think we need to change it.
And in the DARE trial, where it was actually used in, so it is called DARE trial for the right reason. They dared to actually use it, where you would have been scared to use it. And they found, well, it didn't have any bad effects, but didn't have any good effects either. So there's no need to stop it, but you're not going to particularly try it. And that situation has been explained by Manoj, that if it's a sick patient, you're not going to not only use this, you're going to use insulin. So all other drugs are ruled out, including metformin and everything. You probably try to avoid risk of lactic acidosis. So many things come up in that situation. So I think we're coming to the end of it. And Manoj, you mentioned about the Verify trial. So when would you think of using the combination? First, is there a HbA1c cut point? Newly diagnosed patient is coming to you. When will you use metformin alone, and when will you use the combination therapy?
Okay, so when you have a newly diagnosed and you are between say 6.3 and 7, and you're thinking of starting anti-diabetes, are you given whatever lifestyle advice and things you are, probably you could go with metformin alone. But once you're crossing 7, I think experience has taught us that it is better to go with 2 drugs. And then once we have Neeta coming into the picture and talking in terms of reversal of diabetes, then we'll see how things are. But yeah, so it makes probably sense to start with 2 anti-diabetics right at the beginning. Very few who are, grossly overweight, and you can see enough potential for reducing the weight and lifestyle. You could go with metformin alone.
So that question was from Dr. Vivek Gumbar from Punjab. So in continuation of that, I would just like to add that, of course, the reversal and things like that, forget about reversal. Even if you're on drugs, if you're planning for a reversal HbA1c less than 5.6, why wouldn't you try with the drug to get it below 5.6? So why are you only aiming for 7? Because of the 7-7 thing in our mind, what happens is that a newly diagnosed patient who's 7.2, they say, near 7, no need, we'll try the diet. Remember, it's already 1.5% above the normal, and 1.5% is enough to produce a lot of problems. This is like a concession being given, the 7%. A student is getting 30 marks, okay, get at least 70, we're saying. We're not saying that the child shouldn't try for 100, because the child cannot get it. You try to get at least 70, start. Once you get 70, we'll try for 80 or 90. But that doesn't mean that 100 is not our goal. And similarly, I think for every patient, we should be trying to bring it below 5.6. Hundreds of my patients have got 5.3, 5.4. The other day, somebody told me I got 5.1. And so they are amazing. And of course, we reduce the medicines, and in some cases, they go off and they have reversal. But with or without medicine, why are we only trying? That too in a newly diagnosed patient. That's the only time in your life when you're going to get it under control. The only time when you have the beginning, when you have no risk, you're at absolutely low risk, a younger age group, that time also you don't want to try and you want only 7%. You're a goner, and you're never ever going to control that patient's HbA1c, and that person is doomed to develop complications of diabetes. I was going to the extent of saying give insulin at that time and bring it down. Not for somebody 7.3, but somebody 11.5. I'll definitely give him an insulin at that time and bring it down sharply. I've got A1Cs down to 4.9, 5.1, 5.2. Unbelievable. Only when you treat it, you will know. And not that they all dropped off due to hypoglycemia. I put a continuous glucose monitor. I know how it's coming down. I know that they're not getting hypoglycemia. I ease off after they get under control. You should hit hard and hit early if you really want to save the beta cells. Many of those beta cells are only de-differentiated. All they need is a little stimulus and they'll become beta cells again. Your C-peptide will go up. If you're not doing all that and you're treating like a GP, oh, I'll give one drug, then I'll give one thing, then I'll give something else. What are you doing? Why don't cardiologists go and clean up the arteries, isn't it? So we should learn from our peers, and they don't see a thing and say, okay, I'll try one clopidogrel first, then I will try something else, 90% block. I'll now add aspirin also, and then try for another 2 years. By the time you'll have a heart attack and come, now I can do something else. They don't do that way, When they see something, clean it out, and then they do that. So if we see it, we should also hit hard, and then only then we are going to really achieve results. Otherwise, we are going to get stuck, as somebody was saying, our HbA1c is 8.4, 8.5, 10 years later, 8.5, still another 10 years later, 8.5 again. So all these meetings that we're having, what are we doing? We're just talking, nothing we're doing about it. What are we scared? That they'll get a little gentle infection, is it? Or what are we really scared of? These drugs are safe, as she said, Panacea Bio. Meeting, we have Panacea also there of our drugs now. So now is the time to act. Now is the time to take it forward. Bold, be bold, take risks, do that, explain to the patient, get them down, change a new paradigm. The treatment of diabetes. That is what you're all looking for. Not some paltry thing, add one little thing there, and that's not the time at all. We have now to act.
So probably the last question I want to put to both of you is, which patient in your practice would you not like to start an SGLT2 inhibitor? Let's say it like that, instead of whom you want to start, where probably the answer is everyone. But where would you be worried?
If there's a contraindication, a very old person, even age is not a factor. Okay. I know very fit 80-year-olds. I saw a guy, doing all kinds of things, and he's 85 years old, So that kind of a guy, if he comes, I don't mind giving him. His renal function is good, everything is good. He's like, his biological age is 40. I would definitely give him. But if you find a frail person coming already, there is renal insufficiency and the person can hardly walk, no muscles, nothing. And now you go and hit him hard with a SGLT2, you might knock him out, and he may develop dehydration or electrolyte disturbance. Or if there is a as you said, admitted in ICU with something and already having fluid, disturbances. Now you're going to give an SGLT2 also there. It's a little, if there is a definite contraindication, as you said, pancreatitis there, I won't give any DPP4. Why should you give when there's even 1% doubt of that? Why would you go and give it at that particular time? You're taking too much of a risk and with the patient's life, not with your life. So if there is a definite contraindication, avoid it. Gentle infection, recurrent urinary infection, already patient has been, that's the biggest problem patient has had, again, getting urinary infection. Now will you go and give this drug? I'll try something else. I'll probably give a little insulin to get the sugars well stabilized. So apart from that, I don't see, I think every other patient should be on both these drugs, if possible. Neeta, what would you say?
Apart from all the things that you very rightly said, sir, any lady who's trying to conceive, I would not have that patient on an SGLT2 inhibitor, or soon after also lactating or anything. But other than that, yes, risk of dehydration, if it is there, any acute unstable condition where the patient sugars are maybe fluctuating a lot, but these are the contraindications. But other than that, I don't think so. We are judicious in our use, no doubt about it. But these, I think, would sum up the contraindications of using it. Absolute contraindications, at least.
I think we've had an excellent session. We have gone quite a bit over time also. So I think I'd like to thank both Manoj and Neeta for not only a brilliant presentation, but also a free and frank discussion. I always like it when we are frank and speak, speak our minds. And so I've really enjoyed this session. So I'll hand over to Kunal, Pallavi, and the Panacea group for their closing remarks. Thank you very much. And I'd like to thank the audience. I mean, so many questions from all over the country on a Saturday evening when I think 100 other programs will be going on at the same time. I think it's remarkable that, so many people have joined, and thank you all for your questions. I hope you answered all of them. One or two minor ones could have got left out, but we also have to be respectful of the time, your time as well as mine. I've got a few things to do after this as well. So over to Kunal.
Thank you very much, sir. Thank you, Dr. Mohan, and thank you our speaker, Dr. Manoj Chadda and Dr. Neeta Deshpande. And special thanks to all participant doctors, diabetologists across the country, whom we invited, and they respected and they come for this academic treat, which is one of the wonderful, very useful in clinical practice. The use of the DPP4 inhibitor are very well distinguished with the other class drugs, and the use of the DPP4 inhibitors along with the SGLT2 inhibitors. We have come and traveling a very long journey with the Banting and Best, and with Dr. V. Mohan's Diabetes Center, one of the best in the country and in the world. We used to teach to the students and doctors about the WHO guidelines or the step manner approach from one drug, two drug, three drugs, all oral drugs over, then start with the insulin. Now, today we hear from Dr. Neeta that diabetes reversal and the octet with each and every pathological defect to correct with the one drug. With the combination of the drug and targeting every corner of the pathophysiological defect of diabetes. And when we were struggling for patients to reduce blood pressure, to reduce body weight, today we are simply prescribing one or two drugs, and we are confident that the body weight and blood pressure will get reduced. And this indirect effect are now the mainstream prescription point for us, and which is what the practicing doctor needs to look into their patient. And you have discussed wonderfully very well with the evidence-based medicine, with the large number of the trials, with your huge experience of the various socio-economical level of the patients, rural, urban, affordable, non-affordable. And when affordability and quality medicine comes, Panacea Biotech stands well there. So when the Vilda we have come with the quality medicine of select range, and for the dapagliflozin, as very correctly, we know that when we launch voglibose and acarbose, so acarbose from Bayer and voglibose with the 10-12 studies from Japanese company. And sir, you all are there, those who distinguish the two drugs for using on the side effects profile. When the rosiglitazone and pioglitazone has come, then you have distinguished with the BG King studies on the efficacy on the lipid profile. So your academic guidance makes and helps every doctor to distinguish and select the best drug out of class to their patient. When the DPP4 inhibitors comes, you are distinguishing and guiding us which drug to be used. And for SGLT2 today, plethora of the drugs are there, but you are looking at the data, revealing it and explaining to everyone that why and where to use this. And this journey from step manner approach to add one more drug, and with the insulin, now you're thinking of remove the remove the insulin and then remove the other drugs to reversal of the diabetes. That's wonderful, sir. We are thanking you very much, and Panacea Biotech stands always with you for more than 3 decades of this, our journey, and we are always with you, sir. Thank you very much once again. And I request Pallavi, our marketing manager, to give the vote of thanks.
Thank you so much, Dr. V. Mohan. Thank you, Dr. Neeta. Thank you, Dr. Manoj, for being such a wonderful participation here and wonderfully managed slide deck. And the questions were taken brilliantly by Dr. Mohan. Thank you so much. Sorry, my daughter is crying in the background, but I'll try to keep it as specific
It's free background music. So.
I'm so sorry for that. But really, sir, from the bottom of my heart and my entire team at Panacea Biotech, Dicare Alpha, salutes you for today's brilliant presentation and an insightful truth and fact-based knowledge presentation from your side. Really thank you from the bottom of our hearts, sir. And we'll stay in touch with you. Thank you so much for all the participation and all the participants to being around with us. Thank you. See you in the next meeting next month. Bye-bye.
Bye-bye.
Thank you.